Hello, everybody. Welcome to tonight's, I wasn't quite sure whether I should call it a workshop or a seminar, but either or, I think both fit. So thanks all for coming along. I have, over the years, seen lots of patients with convergence insufficiency, and I think it's something that's not very well taught. I think partly because it's not entirely well understood. And it also takes quite a lot of time to try and understand a patient's symptoms and get to the bottom of it. So I'm going to make a plug. Anybody wants to do neurooptometry, please take it on. I mean, I think there are patients that really struggle, and there are patients that benefit from the time and the effort. And it's very rewarding when you can do something for them. And I actually think that there's more that you can do as optometrists for those patients than even I can do. But anyway, so I thought I'd talk about convergence insufficiency, and Katie and I were having this conversation, and then as I got deeper into it, I realized, oh my God, I need to call in the cavalry. So, and I think that it's actually great to hear it from Lora. So I'm just going to talk very briefly because, one of the things that you can't help but wonder is, are there some underlying medical or neurological conditions that you need to be worried about? And actually Laura's going to give the majority of the talk because she'll cover the majority of the scenario, because actually, these conditions, well, the traumatic brain injury, certainly convergence insufficiency, we see a lot of that in those patients, but the history is quite clear. And the dorsal midbrain lesion is probably the one that we fear, but it is very rare. And they won't only have some vague convergence insufficiency symptoms. There will be other signs, so I'll go into that in a moment. And, also neurological conditions like Parkinson's disease. And your patients will come through and they'll have those typical symptoms. Just to go into paranoid syndrome. So they're going to have symptoms that you won't be able to really miss them. They will report having difficulty looking up. They would have those convergence insufficiency symptoms, either because their accommodation or convergence is a problem. They'll have diplopia, they might have oscillopsia, and they're going to have associated neurological symptoms. So you're not going to miss a paranoid. And so the typical triad that's described as the up-gaze palsy. You get the convergence retraction nystagmus, your pupils don't really respond well, and the lid retraction, so you'll be able to see the superior sclera. And just to go into that in a little bit more detail. So what is convergence retraction nystagmus? When you get your patient to look up, you will see that their eyes will converge and they'll retract, and there's supposed to be these oscillations. I have never seen it. So I doubt that you're going to see it. It's going to be, one of you will see it once in your lifetime in this audience, but probably that's about it. It is rare. They get the light-near dissociation, so you'll shine a light on their pupils. They don't constrict, but if you get them to converge, their pupils will constrict more. And then, the Collier sign. And those are, some of the reasons why they get these. And that's why the fourth palsy and the third nerve palsy, they'll get the diplopia from that. So the one thing that you are all excellent at doing is being able to assess discs. And paranoid syndrome can be associated with raised intracranial pressure, which give them the hydrocephalus, and then they're going to have papilledema. So, I think all those things that you do on a day-to-day basis, looking at the neurological signs, listening to their symptoms, looking for visual field defects, any other cranial nerve abnormalities, any disc abnormalities, those will be things that you'll be able to pick up that will give you those red flags. This is something to be concerned about. These patients don't generally present to an optometrist at the outset, so I think you can be reassured by that. But these are some of the causes of paranoid syndrome. If you're younger, it's more likely to be some sort of lesion that's neoplastic, and if you're older, it's more likely to be something vascular like an infarction or a hemorrhage. But you can see there's a whole range of conditions, infections. encephalitis, they're not going to come to you. the metabolic diseases, they'll present to other people. It probably is worth noting about some of the medications, although again, I don't think they'll be presenting to you. So my take home, and this is my last slide because I'm going to hand over to Lora, is that don't fear convergence insufficiency. The majority of cases have no underlying concerning medical or neurological cause. The intracranial lesions, they are rare, and you will have enough experience to kind of know when things are just a bit atypical, when something's not quite right, when it's, if you've got somebody that's well, but that's just got these convergence insufficiency symptoms and no other neurological symptoms, they're not going to have, the chance of them having something intracranially concerning is very unusual. So, yeah, and you'll be doing all of those. So, okay. So I'm going to hand over to Lora because I think hearing it from Orthoptist, and I think this is, I think in this room, what we have here is a whole team effort, really, just providing the services to the community, and we all have our role to play. And I think I lean on Lora a lot, and some of the orthoptic workup is quite time consuming, and it's really great to get all those measurements and have them also as a point of reference. So without further ado, I'm going to hand over to Lora.
Yeah, thank you, Jo, for roping me in and talking to you all. I reiterate, absolutely, I completely appreciate the coordinated team effort that happens, and I know there's only a few of us around, and we're fortunate to have 4 of us at the hospital and here at the moment, and there's one over at one orthoptist over at Findleton Eye Clinic, and so I know that's a real niche sort of thing, and so I'm certainly fortunate that when the patients come and see me, they've actually been exhaustingly looked after, and so I can certainly go, okay, well, I'll narrow it down, and it potentially is a convergence or binocular dysfunction. So yeah. So I've named my topic a bit of a minefield, and so I think when we all come to potentially have a patient that has a convergence accommodative deficit, we go, okay, so what are those tests that I'm going to do, and will I have to give prisms, will I have to give exercises, how will this patient do it, and how am I going to coordinate all this? And so you're sort of like, okay, where do I start, and what should I do? These really, as synopic symptoms, there's so many things that contribute to it, and a couple of those things are convergence and accommodative insufficiencies and imbalance of a binocular system. So here's a table of pretty straightforward accommodative and convergence disorders, and obviously you can branch them into accommodation and convergence, knowing that some patients can actually have both. So accommodative, you can have a deficit, so accommodative insufficiency, paralysis or presbyopia. Excessive accommodation is a spasm, and failure to alter accommodation is inertia from near to far. Convergence insufficiencies are a smaller bag that have deficient is insufficiency and paralysis, and excessive spasm. And this is actually my table, so that I've come up with over the years of just seeing so many patients and just really simplifying it, if you could say that, while looking at that slide. So it just really, obviously, it goes through the 5 types that, as an orthoptist, these are the types that we consider. So insufficiency, fatigue, inertia, paralysis and spasm, and they mostly present fairly similarly, that they have asthenopic symptoms, blurry vision, and they can present with diplopia as well. Just the difference is things like with fatigue, they'll develop it after prolonged use, so doing your tests a couple of times to see if they fatigue, and inertia, just that change in near to distance, and clinical findings. We're going to go through a few of those, so I'm not going to go through every single one of them, and there's some treatments. And again, if you look at the treatment columns, sometimes they're really similar. So if you get the diagnosis wrong and you're on the right path, you're doing something towards their binocular stability again. So similarly with convergence disorders, So this is my table that I refer to, and and often, obviously, because it's convergence insufficiency, they'll present with diplopia rather than blur. So my advice is slow down and take your time, and exactly what Jo said, listen to your patients. And I think that's one factor that is really a pressure in your practice, is time, and having the time to talk to the patients and really do the examination in amongst everything else that you have to do. So some of you may have seen this slide before. I have presented it over the many years that I've been in Christchurch. But I do think foundationals are really important to know, and because accommodative convergence deficiencies are, it's a balance of your binocular system. So if you know what's being imbalanced and your basic systems, you can work it out from there. So I call it the ABC 1, 2, 3. So ABC stands for alignment. So when we look at any patient that comes through with strabismus or binocular dysfunction, we're looking at alignment of their head, their eyes, and their ocular muscles. And B is binocular functions, and there's 3 grades of those. And C is your cycloplegic examination, including refraction, fundal examination, which is pathology and everything. And if we break it down, we can actually define it into the grades 1, 2, and 3. You don't need to know about A, B, C. So 1, 2, and 3. So grade 1, 2, and 3. So simultaneous perception is 2 eyes looking in the same direction with near to equal vision. So in amongst that is the alignment. So we're doing our cover tests and ocular motility. Your vision to see if they have amblyopia or any other with adult patients, obviously macular dysfunction, all sorts of different things. Is their vision equal? And doing a C, just to keep it in the ABC theme, but a fundal examination. Grade 2 is fusion, and I really believe that it's the crux of our binocular system, and stereoacuity, which is the ultimate goal. So if you've got something that's a bit shaky further up, you're going to have a disrupted stereoacuity, but that's what we're aiming for them to get stereoacuity. And with everything in life, I say you have to pass each grade before you get to the next. So if you assess each of those systems, you'll get to see what is underlying. So the things that I ask patients is about their health and medications and history and trauma. And fortunately, I do have the pleasure of having Jo and the ophthalmologist overseeing these patients from a medical perspective, because there's no way that I am close to all that sort of stuff. So the main ones that I do come across with convergence insufficiencies are Parkinson's disease and traumatic brain injuries. So they would be absolutely the most common that I come across. So obviously age, and in this audience I will not talk about presbyopia. So blurry vision, I ask them about the blurry vision, the double vision. Anna Horwood is amazing orthoptist in the UK who has done a lot of research on accommodative and convergence disorders and what works. And she's done a great paper about it's actually whether they've got accommodative or convergence disorders. Some of them will turn up blurry or double, and you actually can't work out which way they are. So doing the whole assessment is really important to isolate which one. I asked them about change of fixation distance, how often they get it, if they improve, if they've had a break and rest over time. I asked them what they do and what they want to be doing, because it actually does help with the ergonomics in recovery, and sometimes you have to change where the computer is situated and all that sort of stuff, and so it just helps them understand what your treatment, they're part of the treatment really. So, and then my patient examination, I'm not going to go through everything, I'm just going to go briefly through those ones that have stayed not coloured. So cover test. So again, this is just a brief summary. So most insufficiencies will either be orthophoric or present exophoric. And the spasms will present esophoric with some sort of eso. This is a table actually we use a lot at the hospital when we're going through whether a patient needs surgery or not for exo deviations. And but I just wanted to bring it in to reiterate that intermittent exos, they're the ones that fall into the category of convergence weakness, and they can go down the pathway of needing prisms and orthoptic exercises and vision therapy. So, yeah. So as an orthoptist, I love a cover test. So my tips are really for these patients in particular, because often it's subtle, and so really doing a slow and intentional cover test and really occluding the eye. So sometimes in patients, I completely use the palm of my hand to completely blank out any light possibly coming in, and especially I've seen it mostly, especially with spasms, so you won't see it, and then you'll completely dissociate them, and they'll just start to do this sort of shaking and ESO sort of movements and sort of nystagmoid type movements. And dissociate even with the smallest deviation. Obviously, do it with and without their glasses, and use an accommodative target. So I use a sticker on my nose, and I don't care what age the patient is. You get to find out if people have personality or not. And so don't use a freckle or a light or whatever you want to use. It's really important to use an accommodative target and ask them about, I ask them about details on it. So yeah, the next part is ocular motility, and so we're really looking for pathology and associated, and obviously the most common ones associated with convergence and accommodative deficiencies are third and sixth. So yeah. So a Convergence examination, and I know this is really basic, straightforward, but that's the whole point, keep it basic, straightforward, do what you do it well. And convergence near point, I tend to use a RAF gauge rather than free space. And fusion, so do the divergence and convergence fusion range. So a lot of literature talks about 8 centimetres being the where it's defective. So, but if some people are symptomatic at 4 centimetres, so 8 centimetres is my guide. So if they're 8 centimetres from the nose and symptomatic, I do something about it. If they're 8 centimetres and asymptomatic, there's times that I won't do anything about it because I don't want them to become symptomatic. And so if the patient is further than 25 centimetres, just think about whether it's actually going to work or not. So that's sort of the cutoff. So know your fusion ranges. So this is just knowing stuff and knowing it off the top of your head. And so for near and distance. Again, this audience I'm not going to talk about in depth. It's about knowing what you're looking at and what the anatomy that's going wrong, and understanding what accommodation is. And obviously using tables that correlate to age. And so amplitude of accommodation is the first thing that I tend to measure. And Dwayne's amplitude of accommodation, and then Hofstadter, who used Dwayne's as a starting off point to come up with his amplitude accommodation. And I quite like using Hofstadter because it does give a maximum and a minimum and a in-betweeny. So RAF gauge, distance refraction is worn, and that can be done uniocularly and binocularly. I tend to use the push-down method, and which I suspect the rest of you do. Minus lenses, it can only be done uniocularly, and they do say that when you measure amplitude of accommodation with minus lenses, it does overestimate your amplitude of accommodation, because they just need to know that that's a letter V rather than telling you, yes, that is clear. And so there's just a difference in resolution. So when you're doing the RAF gauge, they need to say, yes, it is clear. And so they just tend to, so just knowing this stuff when you're doing your assessment to go, okay, that falls within the range and all that sort of stuff. Accommodative facility, really easy with the flippers, and if you're really dexterous, grab some trial frames and flip them in between. And if I don't have flippers, I've loaned them out to all my patients. I grab them from the trial frames and the trial box, and flip in between for 1 minute. And so my normative data is taken from, again, an orthoptic journal, and Fiona Rowe, who is my orthoptic idol, and just knowing the numbers, that 8 cycles per minute binocularly is a normal for a presbyopic patient. So so the main thing that I'm looking for when I'm doing accommodative facility is, are they slow and they do fewer cycles per minute, or are they really slow through the minus lenses? So obviously that's when they have to do, they've got an accommodative deficit. So that's what I'm watching for when I'm doing the facility. I'm just going to briefly touch on relative accommodation. I must say that I rarely measure relative accommodation. I don't find that it fits, it helps me perfectly categorise it into the category, those categories that I talked about initially. All those other tests tend to have defined it already for me, what category the patient falls into. And but as you know, it's positive and negative relative to a convergence fixed point. And then again, the patient reports when they're blurry, when you're adding and minusing in the increments. Yeah, so that's the most current article that I could find of the relative use of it, and yeah. So lag of accommodation and is another component of accommodation, and again, I rarely use it because I am thinking about the bigger picture, and they are not necessarily, I mean, all of them are not isolated tests. We're using it as a bigger picture, and but there are components that that can be assessed. So the treatment. So we've done all the tests and we come to the treatment, and so I've just simplified my table really, and so I can assess each. So accommodative insufficiency, if I think that the patient has accommodative insufficiency, they may need glasses, and it's not exclusive, so they may need some of those things, but definitely I would start them on exercises, and if I do give them glasses, my goal, if they're pre-presbyopic, my goal is often to get them out of the glasses, and if they've needed them, and they're the main exercises that I give. So convergence exercises are just so powerful, and even if they're accommodative deficit, I do tend to say even if you're just doing pen push-ups, it's going to have an effect on your near reflex system. So accommodative fatigue, it does say treat the underlying cause. So people with accommodative fatigue tend to have underlying sort of health issues. They may have chronic fatigue and all that sort of thing, and they're really difficult patients to manage, and because they're just, yeah, it's not fun for them overall. Accommodative inertia is really, I do jump exercises for that, because obviously their focus from near to far is what's sort of the more difficult. Accommodative paralysis, often they need full near add with some prisms. And accommodative spasm, often it's induced by stress, and they need rest, and often they're actually pseudomyopic, and so really doing a cycloplegia refraction to see if any underlying latent hypermetropia is important. So just going through the treatments for convergence insufficiency, and as you can see, they're actually really similar, and doing convergence exercises, fusion range exercises, and because as I say, I really think that fusion really is the crux of our binocular stability, and again for spasm, just treating the underlying cause, and giving them glasses if needs be for a time. So giving glasses, because glasses is the start of our simultaneous perception, to give them the good vision that they need, and sometimes that is to give them straight eyes. And when I give prisms, I try, for accommodative convergence insufficiencies, it actually is hard to do Fresnel prisms. I much prefer you guys to give ground prisms, because they're already blurry, and you give them a Fresnel prism and then you're adding this blur on top of it, so you're struggling through a struggling system. So it is really difficult. So I really appreciate, there's been a couple of patients over the years that I've really appreciated the coordinated care and the change of the glasses that have happened as the patient has improved. They've started with 10 diopter split base in prisms, and then you guys have just lowered it down and gradually gotten rid of those prisms. So just giving them the best optically seeing view instead of putting a Fresnel prism on. And as a guide, I do give them minimal tolerable, because I'm going to give them exercise and I'm going to make them do them, and try. And or I give half the near deviation, and so yeah, that's as a guide. So the exercises, really basic, make it fun. I do all sorts of things. So I have patients that do get it in the shower, and they grab their shampoo bottle and they're doing their convergence exercises. They're eating their cereal, they grab their spoon, all sorts of different things. And I think that's a big thing about all these exercises is compliance, because they're really tedious and boring. And kids, when it's children, they just don't want to do them. So they're the majority of ones that I tend to give. Fusion exercises. So I personally loan out fusion bars, and the patient pays a refundable deposit, and I just send them home with it. Or if they're good enough, I will give them single prisms to do, just sort of depending on where they're at, and again, refundable. I also actually I bought this in. This is what I also do. Once they get really, really good, I actually make up these they're Fresnel prisms, so they're free. They're not $300 like a whole prism bar, and the patient can take those home, and just that ongoing management of doing prism exercises is and yeah, I'm surprised at how many patients I've given those out to. So my advice to patients is, I tell the patients, do them 10 times a day, do them 10 repeats. And really it is a little bit of reverse psychology, because active management is said to be 5 times a day, 5 repeats. So really what I'm doing is I'm telling them it's really important that you do them. If you do them, you need to do them to make them work. Okay, so if I tell them 10 times a day, hopefully they'll do some of them. I do tell them that the exercises are powerful. And part of my handout sheet does say that to relax their eyes afterwards, and relaxing your eyes is not closing them and going to sleep. It is staring out at a distance target and making your eyes go divergent and parallel again. And they can take time to improve your system and your symptoms. And just try and persist to overcome those difficulties. But if they are too difficult, and I have seen patients that just simply cannot do them, and I say stop, because it's just making it worse, making your whole being worse, really. And I've just over the last sort of 6 months, I do for compliance, I ring the patients or email them in 4 weeks and just check in and see how they're going, and it's really just to make sure that they're doing them. And then I say that I'll see them in 6 to 8 weeks, so that's 6 to 8 weeks after the first appointment. And I also say to them that it's likely to be an ongoing issue. And so when you, if I see a younger child, I say, when you go to university and doing lots of study, all that sort of thing, and your eyes are just working hard, just remember me, do them again. So patient compliance is a big thing. So regular contact. I'd love to know what you all do, to tell you the truth. And I give them a few options, I just try and make it as fun as possible. And I say change it up, and put a sticker on the fridge and then move your head towards it, whatever, just. And Joe came up with an article recently, and we had a good conversation about some home-based therapy, and really keen to know if anybody is doing any of the computerized stuff. And I haven't properly been through all the links to know exactly how much they cost for a patient. And but my reading, whether I'm a traditionalist or whatever, the reading still comes down to that the simple traditional still work. And and if we're sort of adding that cost, but then again, the cost of coming to an appointment and taking time off work can be a consideration for patients, especially if they live remotely. And that's where I would start to think, okay, can we give these patients, because what they do is like your physio appointments, like it maps when you've done it. And so I would get a link if I was offering them. I would get a link to say, oh, Joe Bloggs has actually done their exercises today, awesome, and all that sort of stuff. So there's that monitoring system that I can check in as well. So I think there's pros and cons. And I did come across this article about, they talk about, it says it in the title, uncoupling your expectations. This is a massive excerpt, and but it says it really well that the traditional still work, and what they're actually finding is some normal patients that were doing these in a laboratory were actually coming out with asthenopic symptoms, because what it does is because they're based on a 3D model, they're actually disrupting that natural neurosensory connection that we have with just simply doing this rather than on those 3D based sort of exercises. So I'm still in the balance. I think there's a place for them, and but yeah. Does anyone offer them? Has anyone read anything? Is anyone excited about them? No comments. No, okay. Well, I'm still on the fence, so please email me if you have some great thoughts. So case one. So I'm going to go through a number of cases, because I think the best way to understand this, that's the dry stuff, is through patients. So this is a young woman who came to us with blurry double vision. She was through ACC, she had a car accident, and the optometrist had looked at everything and said, oh, maybe there's a possible bilateral sixth nerve palsy. So I did an assessment on her, and her vision for near and distance were down, and she, my subjective, gave she was myopic, but it was kind of disproportionate. Like you would expect if she was myopic to be N5, like you wouldn't expect her to be, if she was that myopic, you would expect her not to be N8. She had a variable esotropia with nystagmus, and because of that variable esotropia, she had no fusion because it was just dissociated. Her step 1 simultaneous perception was disrupted, and no stereo acuity. And she had some meiosis when she was doing a cover test, like she's doing this nystagmus type, and her pupils are just going chung chung. And so cyclopedic refraction had showed that she was had a latent amount of hypermetropia. So I thought she had an accommodative and convergent spasm with pseudomyopia, and they're just cutouts from my table. This is when I say the time factor, and whenever these patients come through, it is really important to listen to them, because they are often telling you what's going on. And I just simply asked her, I just said to her, she was a scientist, she worked in the lab, she was a pathologist. All she wanted to do was get back to work. And all I said to her was, wow, this is really hard for you, isn't it? Like, you're just struggling with life. And she said, I just want to get back to work. And then she just proceeded to tell me that her mother had recently died, and she was having to change all her sort of care and all sorts of different things. And she lived out near Rangiora, and so she was having to commute if she could get back to work and all this sort of thing. All these stresses were just impacting on her. And she'd had this car accident, which was just awful. And so her management actually became about self-care rather than optical care. We gave her the option of cyclopentolate eye drops, because with the cyclopentolate her vision got better. And so yeah. So case 2 is a young boy who'd had a couple of months of diplopia veneer and he was having difficulties at school. My assessment showed poor acuity for near and distance. A subjective showed some hypermetropia, and he had a intermittent exotropia for near, really poor fusion, and you can see his convergence fails. And I repeat it 3 times just to check to see if it's fatigue or not. Flippers just non-existent, and reduced amplitude accommodation. So he categorises into a convergence and accommodative insufficiency and an intermittent exotropia. So if we go back to our ABC 1, 2, 3, so my questions really for these patients: do they have 2 eyes? Yes. Are they looking in the same direction? Well, sometimes. He has near to equal vision, but it is reduced with a hypermetropic and correction. He has poor fusion and poor stereoacuity because those foundationals are not quite there. So for his simultaneous perception, we gave him the glasses, and I gave him some base-in prisms. And again, this is where I'm grateful that they were ground into a pair of glasses, just easy. Gave him some exercises and told him to just do them as much as possible. And that's just going back to my guide of how much prism I tend to give. And I reviewed him in 8 weeks. So I know it says 2 years later. I did see him in between, but I thought I'd cut to the chase. And so now he wears the glasses about 20% of the time, and he does the exercises a couple of times a week. And I think that's what we find with a lot of our convergence insufficiency patients is they're kind of doing them, and the exercise by the time you peter out. His vision's so much better even without the glasses, and he has an exophoria which is well controlled, and his fusion range is much improved, and he can do flippers, but they're still reduced. So he just now has a recovering accommodative insufficiency. So the main reason I included him was just to reiterate, ground prisms are so much better than frenal prisms. Do the exercise as much as possible. For a hypermetropic, I never, ever, ever give hypermetropic correction to anyone that's exotropia or exodeviation, except there's always an exception, isn't there? And when they are in accommodative deficit, because they just simply need it to see. And I had initially planned to do all these other exercises and follow the pathway through, but all he needed was those really powerful pen push-ups and fusion range exercises. So case 3, there's a middle-aged lady who was developing some headaches, an eye strain, words were jumping, and again, listening to your patient, she was struggling for that focus from far to near, and with a change of focus. She was currently in those glasses down the bottom. So she came and saw me, and again, her vision mildly reduced, and even with the increased prescription, she's not coming up. So she has a small exophoria, pretty much no fusion range, but convergence absolutely fine, and her accommodation amplitude reduced. However, obviously, because she's in a presbyopic age range, there's no normative data, and you are expecting it to be reduced. So she, by her definition as well, is accommodative inertia because she's struggling for near to distance with a poor fusion range. So again, ABC 1, 2, 3. So she has poor fusion and poor stereoacuity. I sent her to get her glasses updated, and again, I just do a subjective and rely on your expertise, please, to do a proper subjective, and I asked for them to increase. I gave her some jump exercises and flipper exercises, and I just gave her +1s because she is in that presbyopic age rather than +2s. 8 weeks later, and she's just said to me, "Oh, I'm just so much better." And this is the difficulty. Like, I'm still on the fence whether it was the glasses change and just the added effect of doing these exercises. But I still think that go through your steps, and if it fits into those categories, give it a go. And like, if the patient comes back and they're improved, that's a win. Okay, they're not going to hurt, those exercises. Well, usually. So case 4, patient came in, fell from scaffolding and having diplopia veneer, completely unable to read, and we did an assessment, N48, and so yeah, completely loss of convergence near point, and had no accommodation either. So he had convergence and accommodative paralysis from his head trauma, and we gave him some prisms, and I saw this guy in 2006, and I'm pretty sure he's doing exactly the same thing. So he certainly hasn't had any surgery through the public system. So yeah. Case 5, and I recently saw this guy, and so he's works as a media production guy and loves his job, and has been trying to find a reason for his sore eyes for a couple of years, and he has seen 3 optometrists. And again, this is where I'm so grateful that everything has been exhausted with dry eyes, all that sort of stuff, and he's like, this just does not work. And so he was so desperate, he was thinking of a career change, and he really loves his job. And so he is bilateral myope, and he didn't describe any frank diplopia. So when I measured him, he had an exophoria underlying without his contact lenses, with his glasses, for greater veneer, and his fusion range was down, and his amplitude of accommodation was reduced, and he was completely convergent. So I categorised him as accommodative insufficiency. And so I sent him away with some fusion exercises, and again told him to do lots and lots and lots. He is the first patient in my 20 plus years that has said those exercises are refreshing, Laura. Thank you so much. And I was just like, right, okay. And but you can see his fusion range is just increased so significantly, and his control. So yeah. So case 6. So I've given him, he's got one of these to take home, and it's I've put a 20 diopter because he can now fuse a 20 diopter base out, and I am sure he's doing them. Case 6 is Miss T, 4 months of horizontal diplopia, and just sits there with her eyes closed. Eye closed, monocular lid closure. So she has convergence weakness, exotropia, and poor fusion. And so for her convergence, she fails at 20 centimetres. And if you remember back, 25 centimetres is kind of like, is it going to work? Is it not? And she has poor accommodation. So she has convergence insufficiency. And so I told her to get some glasses, and with prisms, go back to my 1, 2, 3 steps, and do some exercises, do them. I'm going to see you in 8 weeks. So she came back in 12 weeks, and nothing much has changed. And so actually down the track, because of my close association with other colleagues, she had a left medial rectus resection, and this was actually 8 months after I initially saw her. So she was trying to do all the therapies and that sort of thing, and it just was not working. So this is my thing, that sometimes we're just looking for the most comfortable vision, but it is about going through the steps and telling the patients it does work, and it can work, and looking out for those things that just it isn't working, and then refer on. And I think Joe jump in and tell me. The things that I think are referrals are if you want to just check what you're doing, and if you come to the complete exhaustion of, I don't know what this is, if there's any potential pathology that Joe has touched on. And and they're the main things. Otherwise, more than happy. Like, that's what I feel like my role is, to help with the diagnosis and then send them back to you guys to be handling the care. And so I put this slide in because closed head injuries and traumatic brain injuries, they can be just completely left field, and obviously there's other symptoms like photophobia, all that sort of stuff that comes into it that they're just so much help with other optical aids, and as I say, sometimes it is just providing the most comfortable vision rather than your ideal goal of, yippee, I've achieved orthoptic genius. So part of my explanation to patients, I do tell them about the neuroflex, because I think that they need to understand the inner workings of accommodation and convergence and the intimate relationship. I tell them about simultaneous perception, and I do talk about most comfortable vision. So my summary really is to come back to your basics, do the workup, and then see which category they fall into, and work on those exercises. And good things take time. Yeah. That's it.
Thank you, Laura. That was awesome. Does anybody have any questions or want to add anything or make any comments?
I just wonder, what's your so you obviously see them at sort of that 6 to 8 week mark, and then if the exercises have been working, do they carry on doing them like that, or do you give them sort of maintenance exercises that they should carry on with, or do you just see them when they're symptomatic again, or what?
Good question, because it is really an individual basis. So if they are significant and really symptomatic, I see them more regularly. So I will see them every 8 weeks for a while, and then I do tell them essentially, this is what's going to work. Okay, if it's working for you, it's what's going to work. You know my number. Okay, and I do leave it up to them to contact me, and they are more than welcome to have my email address and that sort of thing, and just to check in. So I do have some patients that just check in every now and then and go, can you look at my system again? And or they just, I have one patient from the West Coast that emails me and says, I'm just doing them again, Laura. I'm like, okay. So, which is fine. So it's hard to know. I do give them maintenance. So I say to them, look, at least do, if their system is back to within normal ranges, I say keep doing them. Like I say at least 5 times a week. So then it comes down to 5 times a week. So that's my ongoing maintenance. But you'll see them 3 years later, and they've done them like last week because they knew they were coming to see you.
Because they knew you.
Yeah. So yeah, it is hard. Yeah.
Yeah, I think Laura and I were discussing about some of those, why some of those office-based computer programs work is actually because somebody's sitting there next to you and making you do those exercises, because they're really tedious. And you know, and any kind of rehabilitation exercise, if anybody's had physiotherapy and then the physiotherapist says, go home and do these exercises, you know how compliant you are or not. So I think, you know, it's similar with these tedious exercises, and you know, maybe that's why there is value in those computer-based programs, but I think they're just pricey. So actually, when I was reading those articles, I was saying to Laura, do you know anybody that does them in Christchurch? And I don't know, it doesn't seem like anybody's got any.
You know, the orthoptists do it, like all the orthoptists in New Zealand, none of them do them either. So, but we are a traditional group, I must say.
I mean, the trouble with the literature about, you know, that talks about vision therapy, it's almost such a dirty word, because there's so much expense attached to it, and then the literature is very confusing, because vision therapy, you know, is it for those intermittent exotropes? Is it for the convergence insufficiency? Is it for, you know, amblyopia? Is it for, you know, so I don't think there's a lot of clarity in the literature as to what vision therapy actually means, and you know, what it's actually doing. So I think it's something that's going to probably become clearer with time. But I think the barrier is the cost involved, and it does seem like a lot of that information comes out from the States.
I think kids are more interested in a computer device rather than doing a Brock string.
Yeah.
Yeah, what's your private referral fee?
For SES, so I work in lots of places. SES for a child it's 100, and for an adult 160. Set by SES.
They're pretty time-consuming assessments.
I do get half an hour for each patient, so it is really really grateful because I do need to do that's just part of it. Like all those patients, I do pretty much a full neuro workup on them as well, and oculomotility and stuff. So.
And if a referral's sent through, do you? So I've had a couple where I'm not sure if it should go to Joe or yourself. So I've kind of overlapped it.
Yeah.
Do you guys work and look at it? And
Absolutely. So Jo is here more often, so often she will triage it. Mahesh, Jo's secretary, who's soon retiring, is amazing at knowing which category. But both of us, we'll both look at the referrals and go, okay. And often Jo, with any of the neuro patients anyway, Jo wants me to do a workup as part of it, and so they'll see me first, irrespective, and then Jo often looks at the report or sees a patient.
There's, as you all know, a full orthoptic workup is quite time-consuming, and then when you get those complicated neuro patients that come through, you've got quite a lot to work through, and they've got lots of symptoms, and you've got a whole neuro-ophthalmic system to get through. So that's where I really lean on Lora a lot. I mean, I do the cover test and all that sort of thing myself, but to get some baseline measurements, especially for anybody that you're going to be treating surgically, it's really nice to have those, and then you can kind of get consistency and then make a surgical plan. And even with prisms, the thing is that they go through the trial of prisms, and for some of you can do it with Fresnels, and that's great. Laura can do that, obviously. And some patients they can't get past the blur induced by the Fresnel prism, and you then have no choice. It's a test that is worth going through because it's much less expensive than actually having the glasses made up. Especially when you know that sometimes those glasses are going to be a temporary measure. It's a lot of money to spend on something that they're not going to use, they're not going to need long term, but it's just part of the process, really. Yeah. So.
Actually, that's probably the question that I have for you guys. How easy is it if the patient did get prism correction? How easy is it to change it if the patient does need, like if they trial ground prisms? Is it easy to send it back to the manufacturer and say, actually, I want 6? Right. So, yeah.
Costly. But
okay.
You can do it.
Yeah.
It's quite easy to do. But
Yeah.
it's
Okay.
cost,
Yeah. Okay, good. Well, that's why we do the friendly prism.
But I also think from some that I've seen that have had diplopia and need prism, they're so grateful to get rid of the prism. They're like, I'll pay whatever, just make it happen.
That's so true.
They can't cope with diplopia, and if it means they can go back to work and actually make money, they're quite happy just to do what they need.
Yeah, absolutely. Yeah, that's true.
Great. So if nobody has any other questions or comments to make, I thought it might be, Belinda, sorry, I don't mean to put you on the spot, but I thought it would be nice to introduce Belinda Rendell. She's our new practice manager. So, feel free if you have any queries. Belinda would be quite happy to address them. And we take for granted that you know Marie Taylor. She's our clinical charge manager. So, she's been associated with SES for a long, long time. So, again, if you have any clinical questions that Marie can help you with. But yeah, we appreciate your support and your referrals, and I just love being able to have this relationship with you all, just to provide a great service for our community. And I think it's everybody in this room has a role to play, and I think it's really wonderful. And yes, Mahesh, my secretary, is retiring. I'm going to miss her dearly. But I have Supal, who some of you may know from previously worked with Malcolm, and she worked with Anthony Edgegood for a time, and now she's coming to step into Mahesh's shoes. So I'm very blessed to have somebody that's got clinical experience. So she won't be too much of a drop in the deep end, although it's a new subspecialty for her.
Mahesh will be really missed. She's amazing. I'm going to sit down.
So feel free to come and have some food and stay and chat and come and say hello, have another drink. Thanks very much for coming.
Thank you.